So I'm Brad Williams. I'm Director of Research for the Jane Foundation, and I am living with LGMD2B. So today we're excited to have three distinguished panelists. We have Noah Lechtzin, who's a pulmonologist from Johns Hopkins University, and he will be joined by Amy Fulford, who's a respiratory technician, and covering the cardiac part of the presentation, we have Han Kaur, who is a cardiologist at Nationwide Children's Hospital. So we will, and just as an intro to this, muscular dystrophies and LGMD in particular cause weakness, which can be debilitating, but the primary threats to a person's health are cardiac and respiratory involvement. And they don't occur equally across different LGMD subtypes, which is one reason why it's very important to figure out what subtype you have so that you can be aware if you're at risk for cardiac and respiratory involvement. And it turns out both of these are manageable, but you need to be proactive. Forewarned is forearmed, however that expression goes. You want to sort of keep ahead of any cardiac and respiratory involvement. So our first, okay, let's see. Guess if you could advance the slide. Okay. So our first presenter will be Han Kaur, who will talk about cardiac involvement.
Good afternoon, everyone. Thanks for those who are staying. I know there's lots of great sessions with that. So I'd like to thank the organizer really for giving me the opportunity to be here, and everyone else for staying with this. I'm going to talk about cardiac involvement and management. So here's my disclosure. I'll talk about use of gadolinium contrast agent for assessment of scar. Otherwise, I work with a lot of different partners, both industry and non-for-profit organizations, and education is really an important piece for me. So here's the objective. I won't go over the details of this except within my talk. So as you really heard throughout the whole morning session, really knowing your LGMD subtype is really important with this, because unlike Duchenne, with dystrophin deficiency, it is ubiquitous everywhere. In LGMD, the various protein issues affect sometimes predominantly skeletal muscle, sometimes combination of both skeletal, cardiac, and different parts of the cardiac muscle, and also respiratory. So I think knowing your LGMD subtype, specifically for cardiac, I'll focus on, can affect your risk of cardiomyopathy and then arrhythmia. We'll go into details of that. So looking at this paper here, so I took this large paper here and then kind of tone down what is, so this is kind of the big home picture, if you will, central illustration. The red part are the ones that are high risk for cardiac involvement. The kind of yellow-orange is the one that has some moderate risk, and then the one that's in green is unknown risk, no reported risk, or the current studies that they use may not be accurate enough to do this, okay? So I think we're evolving in terms of understanding disease, but also how we look at the disease. So certain mutations certain mutation affects the heart muscle, conduction system, or both. Know that your heart muscle disease leads to what we call cardiomyopathy. I'll go over the details of that in a second. Lead to heart dysfunction. Now that can also then lead to arrhythmia. On the other hand, conduction issues, okay, in your electrical system of your heart can occur, and that can also lead to heart dysfunction, cardiomyopathy. So they are not mutually exclusive. They actually, in fact, they are actually tied together. So let's go over briefly what cardiomyopathy is. It's a really disease of heart muscle. So no matter what disease you're going through, essentially you go from normal to abnormal. At the end of the day, you actually have abnormal function. So cardiomyopathy is really occurs when you have evidence of abnormality that can occur from having scar burden to ultimately, bad function. I think people think about, cardiomyopathy is really, at the end of the day, you severe dysfunction, but that's really not true. You actually have evidence of early disease. Just like with your skeletal muscle disease, you start having a little weakness and, eventually needing to be in a wheelchair. Same thing with that, and then conduction system can occur from both. So ultimately, this leads to a phenomenon called heart failure. Okay, I think I went one slide too soon. Okay, so one of the things that we see is that, heart disease is actually very common. I think it was mentioned earlier in the general population. That is from aging and various issues. Now, in certain genetic disease, especially in certain LGM subtype, your risk is much higher. Now, I think for those who have LGMD, even though you're low risk as you get older, because you don't have the classic symptoms, it may be hard for your cardiologist who managed you or your doctor that managed you really to understand you actually have potential risk. Can be fast, okay, or can be slow. And it really eventually leads to your heart not squeezing well. So that's from the heart muscle part. And then you can have what we call arrhythmia, okay? So for example, in LGMD 2ER4, which is the beta sarcoglycan, your heart rate can actually go really fast, and then that can actually lead your heart muscle to fatigue and then develop what we call heart dysfunction and cardiomyopathy, and eventually lead to heart failure. So heart failure is kind of a catch-all term in some way, and I think it's really complicated, but it doesn't really mean the heart is actually not working. It means that it fails to meet the demands of the body, okay? So it can occur typically when your heart function is not normal, but can occur when you have increased demand, when you're sick, and then or when you get some kind of viral infection, you're not able to keep up with demand. In the beginning, it can be, just like everything else, it is compensatory, but at first it eventually becomes harmful. All right, so when we talk about heart failure management, right, in the United States, it is the most common disease, and it is used. So these heart failure symptoms you can see on the right here in the blue, you can look at each one of these symptoms. You may say, gosh, I might have one or all of them at any given day. Do I have heart failure? The whole point of this is that many of these things are dependent on you moving and walking, right? So in neuromuscular disease, because your skeletal muscle disease is progressing, it is not as easy to assess heart failure symptoms. All right, so let's take a look at the literature review, what it says. I think you have to begin with literature. With ultra-rare disease, it is really, really challenging because not a lot of these things are reported. So I'm going to compile the autosomal dominant into kind of one group here. So if you look at these papers that I was able to review, these papers are not a huge number of patients, but I think at the end of the day, the types of technique they use, it really reported that there were either no comment on cardiac risk or the cardiac risk was thought to be low. Caveat is that the type of cardiac analysis, diagnostic test is really important in determining disease. So that's an important piece when you review literature and when you yourself go get your care by a cardiologist or your physician. All right, and now looking at the literature overall summary, you can see that the sarcoglycan subtypes generally have high risk. Specifically, the 2ER4 have both what is considered a primary cardiomyopathy risk as well as a conduction arrhythmic risk. And then you have the fucotin and the 2I and the 2J also are considered high risk with this. So now I'm going to kind of go to one specific LGMD subtype. This was presented earlier, so I won't go over the details of it, but in the cardiovascular part, it reported there's really no significant cardiac risk beyond the general population. So this is by Mo et al. In about 2022, sponsored by the Jane Foundation's study here. Large population, with this, and the electrocardiogram actually show abnormal P waves. So the conduction system was just a little slow, but the arrhythmic issues with being too fast, such as atrial flutter, atrial fibrillations, were not really common, but occurred in older patients. So it's thought to be, even though the evidence of EKG is common, it's a sensitive test, the evidence of arrhythmia was actually not significant compared to the general population because it happened at older ages. And there was a recommendation about 1 to 2 year follow-up for arrhythmia. Now I'm going to take this back to my experience here. So I have about 100 some odd patients that we follow. I'm only giving you 36 patients because these were the patients that actually had studies that I believe are the most sensitive type study, okay? So MRI is what I use. It really helps us, and I'll go over the details of that in a second with this. So when you look at this, the ones in the red, as I mentioned before, the cardiac risk were high, okay, which is not unexpected, and the one in yellow also were kind of moderate to high. Now, if you take a look at the row number 2, the LGMD 2BR2, the dysferlin, the previous paper had mentioned that the cardiac risk was low, okay? Now, when we look at using a much more sophisticated technique, cardiac MRI, and I'll go over how that is done in several slides, we found that actually 50%, 3 out of 6 patients we had actually had evidence of cardiomyopathy, heart disease, although the heart function was only abnormal in 1 of the patient, okay, for that. So I think it's important to understand that the techniques you use is really important with that. And then when we talk about what does that mean, all right, so if you take a look at LG, which is evidence of scar, the group that didn't have scar, the group that had scar, we looked at this, the age was not any difference between the 2 groups, okay? But if you look at function, right, global function by ejection fraction, if you've gone and seen a cardiologist, you'll either hear shortening fraction or ejection fraction. In the LG negative group, only 1 out of 18, which is about 5.5%, actually had abnormal function. And that was only 54.5, so your doctor wouldn't treat you with that. On the other hand, in the LG positive group, 12 out of 18, which is about 67% of the patient actually had abnormal function. As a group, the heart function was 44.5%, with a fairly wide range because the amount of disease actually is variable amongst that group, even because of age onset as well. So in my conclusion, if you look at this, it's really similar to DMD in that the LGE is a precursor to LV dysfunction, meaning you do have cardiomyopathy early, except you don't have that overt organ system, issue. Same as ambulation, right? So the whole idea of, your 6-minute walk test, your 100-meter test wasn't as good. Ultimately, people say, well, it's easy when you can hide everything until you have to be in a wheelchair, right? And that's the same thing. The LVEF is really when you have to be in a wheelchair for your heart. All right, so the type of cardiac analysis, how you look at your heart really matters, okay? So if you look at ejection fraction alone, only 13 of the 36 patients actually had EF of less than 55%, again, indicating EF is a late finding. Now, if you use cardiac MRI, we show scar, as I mentioned earlier. Now, if you go even further and ask, how did you feel based on the heart failure symptom? Only 4 out of 36 of those patients actually presented some vague symptoms, with this. And it wasn't even with activities. This was just generally, I didn't feel great. Fatigue was the most common. And then I feel my legs a little swollen. Those are the findings. Again, if you sit in a wheelchair, gravity dependent, you're going to have a little swelling. You're tired because your muscles are tired. So I think that isn't really a good way of testing this. All right, so traditional heart failure assessment that is used for ambulatory patients in neuromuscular patients of limited utility because skeletal muscle weakness and then the need to be in a wheelchair when your muscle has declined significantly. So as I mentioned, here's the heart failure symptoms. Even at advanced stages, most patients with neuromuscular disease present with very vague and nonspecific symptoms. Heart failure may be progressive in LGMD and lots of neuromuscular disease, but it is silent, right? You can see the survey done. 5% of people reported cardiac concern, right? Because why? Because they do not feel it, because it's masked by skeletal muscle and pulmonary disease. So how do we look at the heart? Well, we can do one of 2 ways. Most of you guys, if you had a cardiologist or someone see you, you could probably get an echocardiogram. Some of you may have had a cardiac MRI. All right, echocardiogram is great. It can go everywhere. It's readily available. It can be done quickly. It's a first-line tool. Now, disadvantages, you can see on top, a patient who's, body habitus, the ultrasound is hard to penetrate, larger structures as we get older. Unfortunately, as you get older, it's harder to see as in the bottom panel. If I can't see something, I can't tell you something's wrong, right? And it only detects global function, all right? So what does cardiac MRI offer beyond traditional echocardiogram? So on the other hand, you take a look on the right, a younger patient with normal heart function, image is really good. On the right, an older patient with really, terrible function, right? Yes, the movie is playing, but this patient, the quality of image is great. So cardiac MRI really, just ejection fraction alone, actually offers you much better way to look at the heart. And if you, for industry partners that are doing trials, to look at differences in change compared to echocardiogram, you need less number of patients. Why? Because we're not making an assumption. We're actually measuring truly what your heart looks like, the volume and function as well as the mass. So, cardiac MRI in essence offer the ability to look at pretty much everything. Now, obviously for this talk, I'm gonna focus on function and scar burden LGE. All right, so I'm gonna go through that in a little bit. So let's take a look at lessons in DMD when we talk about monitoring and treatment. When I started this in some way reminds me of my experience with DMD when I first started this in 2000, as a trainee, and then how it's changed. So today, in a clinical setting, cardiac treatment in DMD is really based on heart failure symptoms. It's based on what I tell my partners what the patient's heart look like. We're presenting something at American Heart Association, and even in young kids, we showcase that when you have an MRI done, I can treat you specifically based on your disease, okay? And that leads to earlier treatment, okay? And then we can actually titrate your treatment as your disease progresses. So this is used clinically and actually is being used in clinical trials as well. All right, so take a look at the lesson learned. So you can see that in neuromuscular disease, it's a progressive disease. It's a muscle disease that progresses. In DMD, you can see that it progresses, but as the North Star testing, it is heterogeneous, okay? Meaning that it's not the same for everyone, okay? But if you look at yourself, you can actually tell a really good story, all right? So just a moment here. Scar burden is really important piece. It's the early sign of cardiomyopathy, okay? Neuromuscular disease is a very unique pattern where it's in the subepicardial, which is on the outer surface of the heart, compared to a heart attack patient, which is on the inner surface of the heart, we call endocardial. You can see that in the top, what we call gross specimen, it's the white areas, okay? And then in the histologic stain, it's the blue area here. That's evidence of scar formation in your heart. That is the first evidence of disease. And you don't really want to wait until your ejection fraction is abnormal to treat. So in the DMD, we actually show that about 17% of the boys less than 10 years actually had scar, as young as 6.5 years old. When I first started training, people didn't realize that was true, right? And then as you go from, the less than 10 to 15, it progresses. In fact, more than a third of the patient actually have scar despite normal function. By the time you have abnormal function, more than 84% of the patient had scar. All right, what's the impact on scar? Why do I care about scar and not wait until your ejection fraction, not wait until you say I feel bad? Well, if you just look at, if you don't have scar, which is the green here, there's variability, it's a completely flat road, okay? Which means that your disease is progressing slowly. So if you had an MRI, you didn't have scar, you can feel more comfortable that the next year, 2 years, 3 years, the likelihood of your disease progressing is actually slower. Now, the moment you develop scar, which is starting in the red, okay, your slope starts to increase. So you went from just barely noticeable to about 2.2% change in your function per year. Even more than that, I didn't show this, but even more than that, the amount of scar you have actually impacts on that. So why is this important? Well, if you look at this, the impact on MRI is really quite important. So as a case example here of why MRI was really important in our Duchenne experience and also in LGMD is that, so a couple of pieces here. So the y-axis is function by ejection fraction. The x-axis is age of the patient. And the blue dot is when you don't have scar. The red dot's when you develop scar. And then the red line is evidence of the first evidence of global dysfunction by ejection fraction. So you can see DM, I'll call DM, there's a patient that came to us late, heart function was terrible, lots of scar. We did everything we could. Unfortunately, the patient passed away in 2 years because, but he had no symptoms. That's why he was never referred. After the initial experience, we actually started doing patients really early, guidelines would change, and we started treating patients based on guidelines. So this patient had 3 MRIs, started treatment, and then his first MRI on the fourth dot had a little scar. Function was still normal. So if you just look at function only, you wouldn't treat this patient. And we treated him. His function got up just a little bit for that a little bit. Again, because we're treating, we're not curing, we're treating, we're actually giving him time. Now, his disease continues to progress. 3 years later, his function drops down again. And we said, well, his function is still about the same, right? But his scar was maybe a little bit more. At that time, people weren't thinking about why we should be treating based on scar. So we left him alone. And unfortunately, after that, 3-4 years later, his function then declines. And we said, oops, we had to jump on that. Although we did a good job and we're maintaining his heart function, over 13 years, his proactive approach in this patient, 2 or 3 years older than the first patient, he's maintaining a fairly controlled heart failure management. no symptoms at all, but he's actually doing relatively well compared to what the other patient was. All right, so let's look at how often we monitor arrhythmia. Okay, quickly, irregular heartbeat is too fast or too slow. Okay, top chamber is called atria, bottom chamber is called ventricle. And it can be, just essentially tachycardia of some sort, and then putting ventricle atrial. And then, or too slow, which is bradycardia, it's because of either conduction, delayed, just as in the previous paper, or complete heart block of some sort. All right, how do we monitor? So there's been some paper that says probably electrocardiogram is really sensitive. If it's completely normal, you may or may not, you may be okay, but sometimes it's not the best test. If you have palpitations, you can put them hold to monitor for 24, 48 hours. You have persistent symptoms that are either not common, we could put something called Xyl patch, which is longer, up to 14 days. Despite all that stuff, you still have symptoms, we don't catch you, we can put what we call an event monitor for 30 days, okay? Now, let's look at medical therapy, okay? Current treatment therapy, like everything else, is all based on adult heart failure experience, not based on pediatric data for children, not based on disease-specific for LGMD. But it does, in many papers, have shown to improve survival, slow disease, alleviate symptoms, so that when the cure happens, you're in the best shape possible. So I'm not gonna go over the details of this. The greens are a standard treatment, okay? So the ACE and ARB, or the enalapril, lisinopril, perindopril, and losartan are your first line. Those are what we call afterload reduction. It makes it easier for your heart to pump, okay? The angiotensin receptor antagonist, spironolactone and eplerenone, both work equally well. What they call the kind of additional, almost kind of an anti-scar, anti-fibrotic. And then when your heart function declines, then beta blockade gets added. The other two that's in the red, glycoside and digoxin and diuretics, they're used in specific case. For example, water pills. So if you have a lot of swelling, or if they take a chest X-ray, your lung looks wet, they can give you that. There's a newer treatment strategy now, which is really nice from the adult, which we've been using in pediatric as well as in Duchenne. The neprilysin inhibitors such as Entresto or the SGLT2 inhibitor, that are available now that can be used when your heart function goes down. So I think they're a good option. But again, if you don't know, you can't be treated. And then when your heart completely goes to a certain stage, we can use infusion medication. Now what happens either from conduction or heart failure, you may have your heart beating too slow, which we could potentially use a pacemaker to help make it better. Or if your heart goes too fast, abnormal fast, you can actually what we call a defibrillator. What if you did everything and, or you go there for the first time, what are other options? Now, these are obviously really late-stage advanced therapy, so we can put devices in called left ventricular assist device. These can be what we call a destination therapy, meaning that that's what you're going to be on, or bridget transplant. Bridget transplant essentially is, transplants is hard because there's not a lot of organ, and you also have to be healthy in your pulmonary as well as your other pieces to be able to receive that. So it's likely a limited option for a small group of patients. So in conclusion, I think knowing your LGMD subtype really helps predict your risk and allow earlier proactive treatment of your cardiomyopathy, heart failure, and arrhythmia. High-risk subtype to me should be monitored early, and frequency depends on what findings you have, including evidence of LGE or scar, if your heart's dilated or your heart is functional. And cardiac MRI has been really shown to be clinically useful in many diseases. In neuromuscular disease, Duchenne has been a really important lesson learned for a lot of neuromuscular disease with this. I think there's a lot of lesson learned that we should be taking into LGMD and other neuromuscular disease. And don't wait for your heart to decline to consider treatment and getting assessment, because evidence of disease early is preventative. Okay, in the United States, we spend hundreds of billions of dollars for preventive care. In LGMD, you have 100% risk in certain subtype of developing heart failure, yet you can see the survey after survey, what is your concern of your cardiac risk? Less than 5% of you are concerned. Why? Because it's silent, okay? So it's really important to use diagnostic tests to understand what you look like, because without that, you can't be treated. If you're using really broad spectrum testing, you're gonna be missing that, okay? And then for those of you are getting older, managing your blood pressure, your cholesterol, all these things, not smoking are really important. And then, same thing as you get older with LGMD, if you don't have symptoms, your internist is not going to refer you to cardiologist. When you get referred to cardiologist, he or she's going to ask you about the same symptoms. And because you're in a wheelchair, they don't understand it, right? So it's important. I was talking to my friend Edmund here, same thing, right? his cardiologist doesn't know what to do because he has no symptoms with that. So it is important to be, with someone who actually understands your disease and really be proactive. Unfortunately, you have to be the educator for lots of people because of this being really rare disease. Many people do not understand it. So it does take a team. You do deserve to be treated by people who understand your disease. So thank you really much. One quick shout out to Callie Brazo, who I met at the MDA meeting, and really thanks for connecting me with Bradley and the rest of the team, and really an opportunity to be here. And thank you all for joining the session, and then really for you as patients just being here and really pushing us. Every time I come to these type of meetings, I'm just innovated, to really, really want to do more because, as you said, connecting with people is really what makes you want to do more. Thank you.
Okay, so next speaker will be Noah Lechtzin talking about respiratory involvement.
Thank you. Good afternoon. I'd like to thank the planning committee for the conference for inviting me. It's a pleasure to be here this afternoon. So while I'm waiting for the slides to come up, I'm a pulmonologist at Johns Hopkins, so just about an hour or so up the road. And as you heard, with LGMD, the limb muscle weakness can be quite debilitating, causes all sorts of challenges, but it's really breathing and cardiac issues that can tend to be the life-shortening problems in LGMD. And as the American Lung Association used to say, if you can't breathe, nothing else matters. Let's see here. So I'm going to just show a few slides of data and then talk more about what I do as a pulmonologist and what our various options are for treating the respiratory complications of limb-girdle muscular dystrophy. So as you've heard over and over again this morning, genetic diagnoses and understanding the subtypes are really important, and natural history studies are really important. So 20-some years ago, when I first started seeing patients with limb-girdle muscular dystrophy, we sort of knew some patients with LGMD develop respiratory problems, some don't, and we didn't know a whole lot more about how to figure out who was who. Fortunately, we've learned a lot over the years. I'm going to show a few slides from this very recently published study out of the UK. There's a handful of studies that have looked at respiratory complications in limb-girdle muscular dystrophy, and in my opinion, this is really the best one. It's the largest, and it has the most follow-up. And so in this study, they followed 156 patients, followed for some as long as 22 years, but a median of 8 years. Of those patients, 25 or 15% were non-ambulant at the time they entered the study, and only 2 or 1% were on non-invasive ventilation at the time they entered. I'm going to talk more about FVC, or forced vital capacity, and what that measurement is, but an FVC less than 80% is kind of a reasonable measurement to say there is some degree of respiratory muscle impairment. And so almost 40% of their population had respiratory muscle weakness at baseline, but only 12% had symptoms. So just like we heard with cardiac impairment, a lot of patients with LGMD who have respiratory involvement aren't really symptomatic. So you need to pay attention and look for this. And so this table here shows the 5 different subtypes that were in this study, so R1, R2, R9, R12, and then they grouped the handful of sarcoglycan patients into one group because there were only 14 of them, and they tend to behave fairly similarly. And what you can see is the column there, patients FVC less than 80%, that's the number of patients, and the next column over is the percent. And you can see the percent with respiratory muscle weakness varied quite a bit. So the R9, 78% of those patients had respiratory muscle impairment, whereas the R12, only 16%. And there's a spectrum between the 16 and the 78. And then in the last column, it just shows some of the other factors that were associated with respiratory muscle weakness. So in the R1 patients who were also using wheelchairs at the time were more likely to have respiratory muscle weakness. In R2, patients who had a later age of onset and male gender had more respiratory muscle impairment. In the R9, wheelchair use and also being non-homozygous for the L2761 mutation. And so I think, this just shows there's quite a spectrum between the different subtypes. But one thing that's worth keeping in mind is even within the subtypes, there's a spectrum. And so you can't just say, oh, you have R12, you're not going to have respiratory muscle problems. It still does happen. And so, again, we just need to be alert to that and pay attention and look for these issues. So another way of looking at this is a graph showing time to development of respiratory muscle weakness. So again, they define that as a vital capacity less than 80%. It's age across the x-axis there, so going all the way from 7 years old to 73 years old, and the percentage who have developed respiratory muscle weakness is on the y-axis, the vertical axis there. And similar to what we saw before, the R9 is that lower curve to the left. Those patients tended to develop respiratory muscle involvement earlier on, and so about 50% at the age of somewhere around 22, 23 had respiratory muscle weakness. Whereas if you look at the top curve there, which is I think the R12, very few of them over the course of this study developed respiratory muscle weakness. So you can see even up to age almost about 60, none of them had developed respiratory muscle weakness, and then a few over the following years. And then just one more way to look at sort of the same thing is just looking at how much their lung function declined per year. And if you look at the column that says estimated annual change in FVC, or forced vital capacity, again, you can see the R9, which were the patients who more of them had respiratory muscle weakness, they tended to progress more quickly. Those patients, on average, lost 1.5% of their vital capacity each year, whereas the R12, over the course of the study, that column there says 0.002. Essentially, their lung function didn't change over the course of the study. So just, again, showing the importance of knowing the genetic subtypes and understanding the differences, how some have more respiratory muscle impairment than others, but even within each one, there's a spectrum. So hopefully people don't have too many bad memories of high school and college biology, because I'm going to talk a little bit about respiratory physiology, but try to make it useful and interesting. So the lungs, we can keep this pretty simple. Our lungs only do a few things that are relevant here. One is our bodies produce carbon dioxide, and when we exhale, our lungs get rid of that carbon dioxide that our bodies produce. And then we get oxygen into the body. Everybody thinks about oxygen, and it's certainly important, and that's one of the big functions of our lungs. We breathe in air, the lungs extract the oxygen, it gets pumped around to all the organs of the body. What we tend to think less about is how this all happens, and one of the things that is important for breathing are respiratory muscles. So you can have perfectly normal lungs, but if the respiratory muscles aren't working, you can't breathe. And so there are separate muscles that we use to inhale, the inspiratory muscles, and separate muscles that we use to exhale. So the inspiratory muscles, their job is to expand the chest, which then allows air to come in and fill the lungs. And the main muscle that we use for inhaling is the diaphragm. And then there's some other muscles in between the ribs and up in the neck and shoulders that also help. And so this is just a figure showing the diaphragm. It sits under the rib cage. When it contracts, it moves downward and also pushes the ribs out. So it expands the rib cage and allows the lungs to expand and fill up with air. All right. And then the expiratory muscles, so typically the respiratory system, if you contract your muscles, you fill up your lungs and your chest, it wants to get back to that original shape. It's kind of like a balloon. It's elastic. If you untie a balloon, the air wants to squeeze out. The lungs are very much like that. And so for just passive breathing, your muscles contract to fill the lungs, and then you relax and you exhale. But if you're trying to speak loudly or cough or shout, you need expiratory muscles, and those are the same muscles that we use to do sit-ups. So all your abdominal muscles contract to help force air out. Okay, so this is next going to talk about what goes wrong in neuromuscular diseases and specifically in limb-girdle muscular dystrophy. So one of the problems is inspiratory muscle weakness. So the diaphragm and those other muscles that we use to inhale become weak. And what happens is we develop what we call a restrictive pattern, which just is a fancy way of saying the lungs get smaller. You can't fill them up enough. The chest wall also becomes stiffer because if you don't stretch those muscles out, the chest becomes stiff. And both of those things make it harder to breathe, which that little up arrow there is up arrow for work of breathing. The work that's required to breathe becomes more, in spite of the fact that your muscles are weaker. So now your muscles are weak, and you're having to use them more and do more work with them. Also, having weakness of the muscles to breathe makes you predisposed to sleep-disordered breathing. So when you sleep, all of the muscles relax, and if your muscles aren't working right to begin with, they're just going to be that much more likely to run into problems when you're sleeping. And all of that contributes to what we call alveolar hypoventilation, which essentially just means not moving enough air in and out, and that causes the carbon dioxide that your lungs are supposed to be getting rid of to build up, and it can cause oxygen levels to fall, and that ultimately can lead to respiratory failure. There's also this long arrow over here showing impaired cough. So if coughing is one of those things most of us think of as something we'd like to avoid, but that coughing is actually important, and it's a fairly complicated process where you have to take in a big breath and then contract all the muscles, build up a lot of pressure in the chest, and then squeeze that all out. If you can't take a good breath in, you're going to have a weak cough. And then if the expiratory muscles are weak, you can't squeeze and force that air out, and that also impairs the cough. And all of that sets you up for having mucus get plugged up in the lungs and also pneumonia, which, again, can all lead to respiratory failure. And then lastly, and this tends to be a very uncommon problem in limb-girdle muscular dystrophy, but not unheard of, is upper airway muscle weakness. So weakness of the muscles that you use to speak and swallow. So does happen, and people who have difficulty with swallowing are at risk for having problems with swallowing and having food and saliva and other secretions go down into the lungs and causing infections, and again, puts us down the road towards respiratory problems. Okay. So the complications that we see in limb-girdle muscular dystrophy include pneumonia, respiratory failure, which can either be a carbon dioxide level in the body that's too high or an oxygen level that's too low, or the two of them combined. You can get mucus plugging, where the secretions in our airways become thick and plugs up airways. You can get atelectasis, which is a fancy word for saying the air sacs that we need to get oxygen into the body collapse because you're not taking big enough breaths. You can get sleep disturbance. And then another thing to just keep in mind, if you need to have any sort of surgical procedure or medical procedure where you're undergoing sedation, having a compromised respiratory system puts you more at risk for complications from those things. Okay, so what do I do when I see somebody with limb-girdle muscular dystrophy? First is talk about symptoms, and we heard, just like the cardiac problems, the symptoms can often be very subtle. If somebody is in a wheelchair and isn't able to ambulate, it's less likely that they're going to say, oh yeah, I get short-winded whenever I run around the block, because they're not running around the block. But if you ask for more subtle symptoms, you can certainly often find them. And so sometimes people say, oh yeah, when I lie down, it's harder for me to breathe. Or if I bend forward, it's harder to breathe. One thing that we see from time to time, and lots of people aren't getting in the water, but if somebody says, oh, you should do aquatherapy, it'll be really good for you, every now and then I hear from a patient who says, yeah, I was doing fine, and then I got in the water, and all of a sudden I couldn't breathe. And what happens is when you submerge in water, if your diaphragm is weak, the pressure from the water pushes up on the diaphragm and makes it harder to breathe, and so that can be a subtle sign to look for. Sleep disturbance can be another subtle sign of respiratory problems, and often people aren't aware of it. If you're sleeping, you don't know what's going on. And if people are waking up frequently, they often come up with other excuses. They say, oh, you know, I need to use the bathroom, or it's because I couldn't get comfortable. But sometimes sleep disturbance is one of the signs of respiratory problems, and so it's worth paying attention to. Additionally, morning headaches can be another subtle sign of respiratory problems, and that could be a sign of elevated carbon dioxide. Okay, so we talk about symptoms, try to tell if something's going on that we're missing, but we tend to rely on objective measures, and our most commonly used test is what's called spirometry, and we measure what's called the forced vital capacity. The figure here shows what spirometers used to look like several decades ago. It was actually this water-filled chamber with an upside-down container in it. You would blow through a tube that would move the one chamber up, and it was connected to a pen that would then draw on a little cylinder that would turn. Now it's all electronic, but it really does the same thing. And so what we do is we ask a patient to take a breath all the way in, ask them to blow it all the way out, and we measure that volume of air. And then we compare that volume of air to what we'd expect for healthy volunteers matched for the same height, same gender. And then we can say, okay, you know, your vital capacity is 90% predicted. That's normal. We don't see much sign of respiratory muscle weakness. As I mentioned before, we usually say above 80% is normal, below 80% is abnormal, and there's obviously a spectrum. As it gets lower and lower, it's indicative of more severe weakness. It's not a perfect test. There's some learning involved. As people do it more and more, they often get better at the test. If anybody has mouth weakness, it can be very difficult to do the test well because you need to form a nice tight seal around a mouthpiece. And it's very effort dependent and also dependent on who's coaching the procedure. So not perfect, but it's easy to do, very available, and quite useful. There's a number of other tests that we can do. So I think during COVID, everybody got very familiar with pulse oximetry, and put a little light on your finger and it measures oxygen levels. We can also measure carbon dioxide by a number of different methods. And then there's another number of other tests. So sometimes we'll measure maximal inspiratory and expiratory pressures. We ask somebody to breathe in as hard as they can, and we can measure how much pressure they can generate. It's a reasonable overall measure of the respiratory muscles. We can measure how forcefully somebody can cough. And then we might need to do imaging if we're worried about pneumonia or other things going on in the lungs. And we might need to do a sleep study if there's subtle problems that we're trying to sort out and thinking maybe there's something going on that we're missing during daytime hours. All right, next I'm going to shift to, okay, we've diagnosed a respiratory problem. What can we do about it? And there are really two separate connected things here: ventilatory support and secretion clearance. And so what's in the toolbox? So we have sort of two different ways to ventilate people: non-invasive ventilation and invasive. Non-invasive is, and really ventilation is essentially just a pump that forces air into somebody's lungs. And when we call it non-invasive, it means it works through a mask of varying, there's lots of different types of masks, and I'll show some pictures. But it's non-invasive because it goes through a mask. Or invasive ventilation, which means it's ventilation that goes directly into somebody's windpipe. And so that's either through a breathing tube in the mouth or through a tracheostomy tube, which is a tube that goes directly into the windpipe. And then I'll talk about secretion clearance as well. So non-invasive ventilation, here's a picture of some of the different devices that are on the market. Sometimes you'll hear people talk about BiPAP, which is actually a trade name, but gets thrown around a lot, is a common way to use non-invasive ventilation. Then there's also ventilators that have a lot more bells and whistles. Oftentimes we start using these at night. Oftentimes as respiratory muscle problems worsen, patients find that they need it during the day. And we get to a point where some people use non-invasive ventilation 24 hours a day and can do quite well. I'm not going to get in, there's a lot of subtleties about different modes of ventilation, different devices that I'm not going to get into, but we'll probably hear about them in the next talk, and if not, I'm happy to talk to anybody who has questions afterwards. As I mentioned, non-invasive ventilation is done through a mask. There's lots of different masks. There's some that just that are what we call nasal pillows that just fit under the nose. There's sort of triangular masks that fit just over the nose. There's a variety of different masks that fit over the nose and mouth. Oftentimes, what patients really notice is the mask more than anything else. There's the ventilator matters, but what's really on somebody's face is what they notice. And so finding the right mask for the right person is really important. Non-invasive ventilation has been shown to have a number of benefits across a lot of different neuromuscular diseases. So it's been repeatedly shown to improve survival. So people live longer if they use it. They feel better. They have better quality of life. They have fewer respiratory symptoms. They sleep better. They have more energy. And it's even been shown that in some people they have better cognitive function. There's lots of different ways to start non-invasive ventilation. It can be done overnight in a sleep lab. It can be done in a hospital. It can be done at home. And then a lot of it just depends on kind of preferences and resources for the different centers and patient preferences. Often, one of the questions that comes up all the time is sort of when's the right time to start non-invasive ventilation? If you live in the U.S., we're often it's dependent on what's going to be covered by insurance, and most insurers follow Medicare criteria for bi-level non-invasive ventilation, and it's essentially a diagnosis of a restrictive thoracic disorder like limb-girdle muscular dystrophy, and then any of those following four things, either an elevated CO2 or low oxygen levels at night or a low vital capacity or a low maximal inspiratory pressure. And then the last thing I'm going to talk about, secretion clearance. Very important and something that shouldn't be overlooked is coming up with techniques that if you have a weak cough and can't clear secretions, there's ways to manage that. Several different things that we can do. One is what we call lung inflation and manually assisted cough. So people will sometimes use a manual resuscitation bag, so an ambu bag where you put a mask over the patient's mouth or give them a mouthpiece and squeeze it and fill up their lungs and then use manual techniques to force a cough out. There's also a device called a mechanical insufflation exsufflation, which I'll show some pictures of. And then there's a lot of additional measures that we can use if need be, so nebulized medications, airway clearance vests, manual chest percussion that sometimes if these other things aren't working, sometimes adding these can further help. And so these are some of the different mechanical insufflation, exsufflation devices that are on the market. What they do is they apply a lot of pressure. They sort of push a lot of air into the lungs, and then they suck it back out and help clear out the lungs. I'm not going to go into the details of how we do that, but just to conclude, so there's a lot of variability in respiratory muscle weakness between LGMD subtypes, but also keep in mind, even within subtypes, there's variability. Respiratory symptoms tend to be uncommon, and so it's really important to follow lung function serially and be vigilant for these. And then proactive care to identify and intervene on these problems can really be incredibly helpful. I'm going to stop there.
So I actually am going to ask you one question. Sure. If you could comment briefly about, patients have reported that sometimes they've been given a recommendation to be put on oxygen without ventilatory support.
Yep. This question that comes up a lot, and it's a little bit of a complicated one. So if you, hopefully you heard. So the question is about whether some patients are given the advice to use oxygen, and is it okay to do without ventilatory support? So most people with limb-girdle muscular dystrophy, assuming they have healthy lungs otherwise, they don't have emphysema or some other lung disease, most of the time don't have major problems with oxygenation. They get enough oxygen into their body. So most of the time, people don't have low oxygen levels. So I think medical professionals often see somebody who's short of breath and say, let's just give you oxygen, you'll feel better. So often it's not even necessary. But if somebody does have a low oxygen level, you want to be careful, because most of the time with something like limb-girdle muscular dystrophy, the problem is this hypoventilation. They can't take deep enough breaths. And giving them oxygen doesn't fix that problem. And what it can do is it'll make their oxygen level look good. And so if they're in an emergency room or something, whoever's taking care of them says, oh, we put some oxygen on them, their oxygen level's fine now, and they walk away, but the underlying problem still hasn't been fixed, and so if they weren't able to take deep enough breaths and they were hypoventilating, that can just continue to progress. And sometimes people with limb-girdle muscular dystrophy have an abnormal response to carbon dioxide. Most of us, if our carbon dioxide level builds up, we just tend to, our body tells us to breathe more and more. But over time, that response can be blunted. And so giving them oxygen, sometimes can make things even worse, so that they tend to breathe even less. And so, so what I usually say is somebody with limb-girdle muscular dystrophy, oxygen often isn't necessary. If it is necessary, you need to be closely monitored, and you should be receiving ventilatory support at the same time so that that underlying problem gets fixed. So it's a bit of a complicated question to answer succinctly, but hopefully, hopefully I covered that.
Are you at the Kennedy Krieger Center?
So it's funny. So Johns Hopkins and Kennedy Krieger are right next to one another.
We used to go there a lot.
Yeah. And at one point, I had privileges at Kennedy Krieger. I don't at the moment. But I see a lot of patients who see neurologists at Kennedy Krieger and then come across the street and see me.
So while we turn over to our next speaker, I'll just mention that if any of you have not had a PFT recently, I just had one last night, courtesy of Linda Meredith and company. You can get one right around the corner. Okay, so now finally we have Amy Fulford, who's a respiratory therapist. And
So, good afternoon. I appreciate the opportunity to be here. I'm extremely humbled to be able to work with this patient population, and thank you to the Speak Foundation for asking me to come. As an RT, I had the opportunity to support the pulmonary department in actually facilitating the measurements that he discussed, the vital capacities and the cough flow. I actually have the privilege of working with the Department of Neurology at the University of Florida. So I attend weekly MD clinics there at the university, not only supporting the MD population, but also those with ALS or Lou Gehrig's disease. Respiratory therapists will be the ones that will be coming into your home if you are identified to have some impairment in your cough or breathing, that will be assisting you with education on the equipment that has been provided to you, as well as the application with a mask or any type of application for the therapy that's being given. In our MD and ALS clinics, I assess patients, usually in the presence of the physician, on the respiratory status. A lot of the information, such as, do you have an issue sleeping through the night? Are you short of breath? What type of activities are causing you shortness of breath? Do you wake rested? Do you have morning headaches? Things that you can think about at home that is valuable information to us. I usually hook patients up to a SAT monitor, so we get the basic information as far as your heart rate and your oxygen saturation, but we also measure at the bedside your end-tidal CO2, your respiratory rate, and then also listen to your breath sounds. I have the ability to measure vital capacity there in the room. Most of your pulmonary function testing is done in a lab. I use a small spirometer. The advantage to that is I'm actually able to put you in a supine or reclined position and measure your vital capacity, which is not always available through a lab. But it does give us that valuable information. Some folks feel fine sitting up. Is that change in position where we find that there's some involvement that may not be picked up on the first line of pulmonary function testing. I also measure cough flows, so we have an opportunity to see where you are as far as the availability to clear your airway effectively. Your respiratory therapist will also explain therapies to you that are being considered after conversation with your physician, and then make recommendations. A lot of the information that was presented previously is also in this slide, and I do have some of the equipment available for you out in the hall if you'd like to have some hands-on. Guidelines for implementing respiratory care, the insufflator-exsufflator or cough assist unit. When your peak cough flow is below 270 liters per minute, or the strong indication of choking on food or drink, or your inability to effectively mobilize secretions. It aids in mobilization of secretions. It aids in chest wall compliance. It also assists with choking episodes by opening up the airway, and also assists with swallowing if used prior to eating. These units, the two displayed is one is the Respironics T70 cough assist, most folks are pretty familiar with. The second unit is a Byways. Both units are portable, so you have the ability to take them with you. However, neither of the unit has an internal battery. Respironics has a detachable battery that is available, but you do have the option of traveling with the units. Non-invasive ventilation. Again, I do have two of these pieces out available for you for display. So we begin with the discussion. Previously 80%, 70%, the sooner the better. If you do fall into a category where your respiratory involvement is indicated with your subtype. Based on patients' symptoms, again, we do look at supine, shortness of breath, drop in your oxygen saturation, talk about morning headaches and confusion. A lot of times the symptoms that you're experiencing, not waking, feeling rested, having morning headaches, getting up frequently to urinate are overlooked or again contributed to other factors. The purpose of the non-invasive ventilation is to help improve your vital capacity as well as your lung compliance. Again, the units help you stretch out your chest cavity, keep those muscles good and elongated so they remain elastic. It will also improve your daytime fatigue, reduce your morning headaches, and normalize your end-tidal CO2 levels. I have the same question as well. Why am I not getting just oxygen? And the purpose is to make sure that you ventilate well enough. If we were just to give you oxygen, you would still run the risk of having the shortness of breath, elevated heart rate, elevated respiratory rate, and maintain an elevated end-tidal CO2 even in the presence of extra oxygen. Most of the ventilators are portable for you, so you have the ability to travel. I have cases that use their equipment just at night. I have other cases that travel with theirs with the ability of using it away from home, or there's an activity or something where they find that they are more short of breath. Most of the units are battery backup. They have an internal battery that is not available on a standard CPAP or BiPAP unit, but it gives you the chance to travel more frequently. Once the patient has begun using the equipment during the day, we have the option of either providing it with you non-invasively through a mask, either a nasal mask, or with what is called sip and puff or mouthpiece ventilation. This gives you the ability to be able to speak. It's fairly invasive, so most folks do not even realize that you have the equipment. I've actually been able to assist a professor at the University of Florida. She was able to teach another couple of years with mouthpiece ventilation before her breathing status caused her to have to retire. With that equipment available, you are able to fulfill your dreams. Go out, do your thing, be available to not be worried about getting away from your equipment and running the risk of running into respiratory failure. Thank you. Thanks.
So thanks to all of our panelists. So